Good evening, everyone, and welcome to our Victorian Virtual Specialist Consult Information webinar. My name is Helene, and I'm the Workforce Coordinator here at Westvic PHN. I'll be facilitating this evening alongside my colleague Jade. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel, and the link to that is in the chat at the moment. You'll also see our upcoming events on the screen, and you can register for these via our website, and you'll see the link there as well. You may have seen that we've recently launched our new Learn and Network monthly newsletter. It's the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code on the screen. Editions are released on the first Tuesday of each month. There's also a link to that chat where you can submit your education and training requests for inclusion in our 2026 calendar. Just a reminder about our Health Pathways, which is a free online resource with localised clinical and referral information for health practitioners, and your link there on the screen. A certificate will be emailed to you all, so if you could take a moment just to check that your full name is displayed accurately on the screen. If not, or you're unsure, just rename yourself or type your first and last name in the chat box, and that way we'll make sure we get the certificate to you. The event is being recorded, so if you could keep yourself on mute unless you would like to ask a question at the end of the presentation. We do encourage discussion and interactivity, so please feel free to type your question and I'll answer them on your behalf, or during the chat session, you can take yourself off mute and ask that question. Your feedback is also important, so if you could take the time to complete the survey after the webinar, and the link will show that again. Our presenters for this evening are Associate Professor Joanna Lawrence, Director of VVSC, and alongside her is Cassandra Bramston, Operations Director. I will now hand straight over to the presenters. Thank you.
Can you hear me?
Yep.
Thanks, Cassie. All right, start again. Hi, everyone. It can only get better from here on in. I'm Jo, as introduced. I'm a paediatrician, Director of VVSC, joined by Cassie, who's very good at realising when people are not adequately volumized. Thanks, Cassie. She's our Operations Director, already in full swing. And we've got Morgan joining us as well, who's we're very lucky to have as part of our service, who is a GP and works on GP engagement. So we've got a brief presentation that we're delighted to be here to share our service with you, but we really wanted the majority of this to be interactive and to hear your thoughts, your suggestions, and your questions. So we'll kick off. Feel free to interrupt as we go. If you've got questions, just come off mute and interrupt me. Otherwise, we can have a discussion at the end, whatever works best. Now I need to move my slides. Oh, here we go. So what is VVSC? It was set up by a renal physician who recognised that we have a healthcare system that really isn't greatly supportive of primary care providers accessing specialist support where and when it's needed. So if you have a patient in the community that needs some specialist input, at the moment, the major options are to refer that patient to the outpatient system. We know that the outpatient lists are long, it leads to delays in care, reduced opportunities to optimise care while waiting. When we've met with GP colleagues, they often tell us that they don't know what services are offered where, which can lead to duplicate referrals, and there's very little transparency over wait times. And then there's really poor communication back from the hospitals to let you know that your referral's been accepted, how long the wait time is, or even if, often working on the hospital end, some of these referrals bounce from department to department, so you don't even know who's seeing your patient. You can try contacting the hospital. You often get a junior doctor, interrupts their workflow. You get variable levels of advice. And there's often a lot of phone tag involved with that. Or you can send your patient to ED, which we know is a problem. And there's been a lot of initiatives, VVED being a major one, to try and stop presentations to the emergency department. But we hear from our ED colleagues, this is still a major reason for patients presenting to the hospital, is to get a specialist opinion that they just can't get in the community in a timely manner. So this is what we're trying to address. And we wanted to do to create access like you would if you worked in a hospital and you would bump into your colleague and be able to discuss that patient you're looking after, or you'd be able to wander up to the office and have a chat with your specialist colleague. Our aim initially, it started as a service focused on the Northern Health catchment. And our primary model of care was the co-consult. So a primary care clinician tapping into the specialist of their choice, and it started as a Gen Med proof of concept for a 20-minute co-consultation. And it's rapidly spread to be statewide, partly through just word of mouth. We had people reaching out from all over the state. We've also brought on a wide variety of specialists. We now have over, I think, 28, growing every day, isn't it, Cassie? A number of different specialists on offer, and we've also increased the different models of care that we offer. So our primary model is still the co-consult or case conference model, and I'll throw to Morgan to talk through that in a little bit more detail in a second. But I also wanted to touch on the other models that have evolved over time, one of which is our dedicated clinics. So we've partnered with a number of GP practices, most of whom are living more remotely, so rural or regional practices, where they've got a large number of patients that need the same specialist input, and they set up a dedicated clinic that could be run by a GP with a specialist interest, a nurse practitioner or a nurse, and they get all the patients that need to see that particular specialist in on the same day, and the specialist sees those patients back to back with a clinician from the practice. So that's been a really neat model that's emerged over the last few months. And then we've also, through VVED, we're seeing more patients from across the state that have difficulties accessing specialist any care, including long waits for primary care or to see their GP. Some of these have issues that were turning up to VVED and taking, it was the first time they were being seen by a paediatrician, for example. And so they were taking our clinicians off the floor because there was so much that needed to be teased out and sorted to understand what was going on for that patient. It was really hard to discharge them back into a system where there were significant barriers to healthcare. So we've started dedicated clinics that allow these patients to be seen as a direct one-off referral, not looking to replicate what's offered in specialist outpatients, but to understand, is there early intervention we can institute? Is there early investigations, early treatment, and how do we link them into the most appropriate community pathway? We've also recognised that there are a number of clinics that we offer that do need really timely access. So things like thrombosis clinic, palliative care, advanced care planning, and we've got direct referral pathways into those, as well as a lot of our nursing clinics. So we have a paediatric asthma clinic run by a CNC who's excellent at explaining why the preventer's needed, talking through the asthma action plan, talking through the emergency care advice. So really, all of these are designed to get timely access to specialists, to overcome that fragmentation in care where it's all you write a letter, we write a letter, letters get lost, there's questions that go unanswered, and to get patients high quality care in a timely manner. I'm going to throw to Morgan now to talk through the two different models that are predominantly used by GPs and to share some cases.
Thank you very much. Are you still controlling the slides, Joe? And I just ask you to move on. Yeah, no, that's great. Thank you. I'm a GP by training as well, and so there's a few models that you can use to approach using the service. And just for background as to why I'm quite passionate about this, is I started using VVSC when it was in its first iteration, and I was a registrar. And as the models we'll talk through come up, I'll point out why specifically I found it useful, one as a teaching technique for myself and later for registrars that I supervise, but then also for managing patient consults where we were having either differences of opinion between me and the patient on maybe the best route for healthcare, or we just needed a tiebreaker, or where I was pretty confident on starting something, investigating something, diagnosing something, but you just want that double check. Like Joe was saying, that thing you sometimes get more in the hospital corridors where you can ask a colleague what their thoughts are as well. And so the two main ways to currently access VVSC, which is all under Medicare funding from a GP perspective, is through a co-consult, which would be you seeing the patient as you normally would, either in clinic face-to-face, or if you do telehealth. We would, for accessing VVSC, we wouldn't do it over the phone. We'd need video at a minimum, or for them to be in your rooms. And you would bill as you normally would for that consult, so 23 or whatever item, plus or minus any private fees that your practice would usually have. And then on our end, we'd be seeing them as well at the same time. So you and the patient are online together. We will provide the link to you and the patient to join via Health Direct. Everyone meets at a predetermined time online, and then you can all discuss the case synchronously. The main things that are important about the co-consult is that the patient has to be there, which is slightly different to the case conference that I'll mention, and also that we acknowledge very much that everyone's clinics will sometimes run out of time, run out of sync because of just things coming up. And we're working on batching clinics a bit more at kind of start of the day, after lunch, end of the day. So when everyone's most likely to be running on time together. But we also acknowledge that sometimes things get in the way of everyone lining up. And on that note, I'm not sure, Joe, if we're going to mention we're moving towards an e-consults model as well. So I might leave that to come back to, but as a brief comment, that's a system that we're hoping to bring in probably early next year, where if you are unable to do the online appointment, that telehealth appointment, but you're just looking for advice, there'll be a secure messaging service back and forth between, say, like gastroenterology and yourself, mainly for should this person be seen? Is this something which I should be investigating in this way? And then they'll be able to help triage and provide advice on there a bit more asynchronously. I'm always happy to answer questions at the end as well, but I might move on to the next slide, please, Joe. And the other way of accessing is a case conference, which is, we found it a very useful method to get multiple team members together. So the case conference would be under Medicare numbers such as 735, 739. And with those, the main requirement is that 3 care providers must be present for the consult, being yourself as the primary care provider, as the patient's GP, our clinician of, let's say an endocrinologist, and then the third care provider may be the diabetes nurse educator, might be your nurse in your practice, might be the nurse from the aged care facility that you're visiting, might be an optometrist. There's the list on the MBS website of who will be eligible. The thing with the case conference item numbers is that the patient doesn't have to be present for the case conference to go ahead. You just need documented consent that they're aware it's happening, and then you can still go through the normal process. I think, it's good to try and get them there if you can, but it does, if you're approaching that more complex case management, allow a bit more flexibility on when and where and who's involved. there's also, you can also, of course, that's the Medicare numbers, but if you charge on top of that as well, that's absolutely fine. And we've clarified all that through with Medicare as well, and have that in writing if that's helpful. So the only other things that would be probably worth mentioning here are that this is we think probably one of the best models for access. And if when you're booking in, you, taking the diabetes example again, say, I would like to get an endocrine consult, on the booking form, there is the option to request for us to try and help source a diabetes nurse educator if you don't have one in your network, or one is not going to be available at the same time, because we appreciate that it's very logistically difficult sometimes, especially when you're a bit more rural and remote, to get everyone together at the same time. Great. Move on to the next slide, please, Joe. So when we started getting a bit more of an idea of why this is a beneficial system to use, we look at benefits to the patient, and it provides more benefits to yourselves as clinicians. Some of the co-consults and case conferences are available within 1 to 4 weeks. So, for example, if you've got something like quite bad, let's say quite bad eczema, but it's not really, it's going to be probably categorized in Cat 3, maybe 2 to be seen, at most Cat 2, but Cat 3 at a public hospital. And that's going to be a 12-month wait. You'd be able to, through the VVSC, sometimes be seen within a week or two. And there's a long story as to why that is, because of our ability to provide that extra capacity. But it's an option to consider when patients would have to drive a long way, when there's long wait times, or when it's things which would be really beneficial for yourself to be involved in the consult as well, so that everyone's on the same page. And so that links back to why one of my first consults with VVSC, it was a complex Jerry's. It was a while ago when I was a registrar, and the family, myself and the patient, my supervisor at the time, my GP supervisor, we were all having difficulty making the decision on what level of care or which direction we might be looking to go to for the patient involved. And there was a strong preference on the part of the family for an external geriatrician review, which is very reasonable. And so, again, the wait list was quite long, but we wanted to act on this relatively quickly. And surreptitiously, I found out about VVSC. We were able to get a case conference within, I think, about 2 weeks, where it was me, the family member, the patient, my supervisor, and the geriatrician, and all of us being able to message the same, being on the same page. I would give background history to the geriatrician, which may not have come across in my referral letters or via everyone, the patient and their family. And then they were able to communicate to me and the patient and their family all at the same time. We all clarified each other's questions. So at the end of that consult, everyone was on the same page, and there was a joint decision, and all the documentation was done live, and it was extremely helpful. That's just one example of where I found it quite useful. Things like old age psych, we have adult med. We'll go through all the lists of what's available, but there's lots of different facets of how it may benefit you and your patients. You can access the service from anywhere. So from your clinic, bush nursing centres, residential facilities, patients can join from home as well, as long as they've got a reasonable video connection. We found that about 68% of the in-person outpatient referrals could be cancelled following co-consult. What that means is that patients may not need to commute a long way for a consult that they didn't necessarily need to be seen face-to-face for, and could be discussed online, especially with their usual primary care team. And then again, that ability to get answers earlier, teams on the same page earlier, leads to early investigations, and that sharing of management decisions. And patients have found it very helpful in the experience so far. The next slide, please, Joe. Thank you. In terms of benefits to clinicians, the ability to make joint decisions, I think, is something which we sometimes in general practice feel a bit isolated. And obviously you have your other colleagues in the practice, but sitting together all on the same call, being able to have a discussion live with each other, with or without the patient, depending on that case conferencing model or not, leading that to collaborative decision making, it just relieves a little bit of that mental load on carrying it all yourself. But also it gives you reassurance that you're heading in the right direction with how you want to approach management, investigation, and diagnosis. And to that end, the RACGP will credit it for reviewing performance CPD if you log it, and I think write a small reflective piece on what you learned. And furthermore, you will, because there are certain clinicians who work in the service, and if you're meeting with them live online, you will start to potentially build some of those working relationships. And it's always nice just to get to know other people in Victoria who are interested in this kind of healthcare. Thanks, Joe. Next slide.
It's back to me, Morgan.
You.
Is there anything else you wanted to share before we move on?
I think that some of the examples of where this would be beneficial to really think about is if a patient is going to probably have quite a long wait time to be seen in a public system face to face for something which you think will be able to be potentially managed quite easily online, especially with yourselves there. So good examples that we've had come through or from GPs I've talked to are you're really confident it's rheumatoid arthritis, but you just need another opinion, and you think maybe you want to start methotrexate and you need that kind of co-sign off on it. Other things are when there's just long distances to drive, and you think that probably this is an issue where we can sort it out without getting someone to commute many hours, or people who are bedbound or in residential aged care facilities where it's extremely difficult to get to a hospital. So we have a lot of success with certain GPs who do some kind of aged care work where it'll be them, the nurse, which is working with them at that facility, and then the patient who is quite, it'd be very hard for them to get to where they need to be, but you can get the endocrinologist involved, you can get the geriatrician involved. Other things are like young children and kids or families who the logistics of getting them to outpatient departments, especially for, I think we have complex adolescents and in pediatrics, all of the main areas where it's just a bit easier to do it in the patient's own home. So I think there's a lot of examples I can give and go on for a long time, but they're the main ones that we've had direct feedback on recently that have just come to mind.
Great, thanks. And Cassie, you came off mute. Did you want to add something?
I'm sorry, I wasn't really aware I did, but yeah, we have some really good cases where bush nursing services have used, in particular, the wound consultant. And while they're on the road, they dial in from the patient's home and speak to the wound consultant. And sometimes also that flows into an infectious diseases appointment if required. So we also have cross referrals between our VVSC consultants to ensure that, the care is completed.
Thank you. So I just wanted to share this data. This is actually very early data from the first year of our service. And what I find exciting about this data is it's actually now changing where the referrals are no longer, we don't see this drop off in referrals because they're not being made in the first instance. But when we first set up the clinic, 60% of GPs who were using our service had either referred or were planning to refer to an outpatient appointment. And then by the time they had that 1 20-minute co-consultation, you can see the volume of referrals that were able to be avoided. And as Morgan alluded to, that's patients having to travel, that's all that waiting time, so earlier access to care, the robust discussion between the GP and the specialist to come up with a shared understanding of that patient's pathway forward. And those that did need to be seen in outpatient clinics, which might be that they needed ongoing care through a specialist, they were able to have their care that much further along the journey by the time they finally got seen. So all those tests and treatments and early steps were taken so that by the time they were seen, that appointment was so much more high value. And you can see that the majority of clinicians using our service either agree or strongly agree that it's making a meaningful difference to their patients' care. We've got some lovely quotes. Sorry, I'm struggling to drive these. So I'll just read through these because I think these really speak to the value that the service is bringing. So this is one of our GP colleagues who uses our service, says, "I find the VVSC service invaluable. My patients really appreciate it. I'm tending to refer simple things for now that I feel need a second opinion. So medicine moves so fast and, imaging's picking up more things. I don't know everything, and I'm learning a lot from those consults myself." So just that reassurance that you aren't missing something, you're on the right track, has been really valuable for this clinician. The next one was an amazing consultation, very efficient, clear advice, reassurance, and my patient didn't need to attend outpatients, and getting that communication firsthand was great. Great service, high clinical standards, low cost, accessible, easy platform. Again, excellent service to get the specialist confirmation I'm on the right path. I think that really speaks to the fact that as generalists, you're seeing everything and you probably are on the right path, but evidence is also changing really quickly. And sometimes it's just nice to know that you haven't missed an update and that things aren't changing. Excellent for short and sweet questions and confirmation. So a really strong theme there, and great potential for chronic care and improved communication between GPs and specialists. So I really liked those quotes for highlighting where we can bring value and just support GPs in doing their role and keeping the care in the community. This is our list of current offerings. It's growing every day. You can see that we've got everything from a number of pediatric specialties to all the way through the life cycle, women's health, through to aged care, palliative care, psychiatry for both adults and older adults. That is the one specialist or specialty we offer that needs to be a co-consult. So our clinicians won't do direct referrals. We're really keen to hear if there's something missing from that list that you would find particularly useful. We're looking to include rehab. We're in conversations with a few other specialists that are keen to come on board and share their expertise. From a hospital specialist perspective, it's really nice to have the opportunity. We see the referrals come in, and sometimes, as Morgan says, they're referred really low and they're going to have a long wait time. You just want to pick up the phone and address that issue right there and then, and our system is not set up to do that. So this allows us to address those type of issues. Just in terms of how you access our service, really straightforward. Go onto our website, vvsc.org.au. You can see we've tried to break down our specialties to adults and pediatrics just to make it a little bit easier to find the service you're looking for. Amongst adult specialties, you click on the specialty you want. There's a list of things that are really well suited to a co-consult that our specialists have put forward. They're not exhaustive. If you think you can get value out of our specialists through a discussion, please book in to have that case conference or the co-consult, and then you simply book a consult, choose the time that works for you, and it will ask for some details to allow us to make that booking our end. Both you will get an email with the details of the booking time, and Cassie's going to have to help me there. I think that then you have to forward it to your patient if you want them to join. Is that right, Cassie?
Yeah, that is an option. Or a lot of the times patients join with the doctors in the doctors' rooms. But again, it's entirely up to however you want to play that out.
Yeah, great. You can see, as Morgan said, we've made them half-hour appointments. That's just to acknowledge there's a bit of time either side with coordinating everyone's diary, getting everyone on board. Meant to be a 20-minute co-consultation. The fact that it's a shared care arrangement where you have the knowledge of your patient, you're able to present that really succinctly, and our specialists are able to return to advice giver and giving you their expertise on a targeted question, means we can keep those consultations short. It means that it can be one appointment to address, a really long time period compared to if this patient turned up in outpatient clinics and our specialists had to take that history right from the start and do everything themselves. And that's what allows us to be so efficient and to keep our wait times so low and to avoid us getting into the same traps that we see in specialist outpatient clinics. So we're really working very hard to make sure that you can get an appointment within weeks to months and not having to wait a very long time to see a specialist. As Morgan alluded to, we are looking at how we can do this even better. We know that not every patient needs a robust discussion, and sometimes you just want to write, do I need to do anything about this TSH, or the liver function's abnormal, do I need an ultrasound? Just a simple question. And we're hoping to bring in asynchronous communication where you can write us a simple case history with a question and our specialist will get back to you within 72 hours. It may be that they suggest this patient really needs a virtual co-consult or needs to be seen in an outpatient clinic, or it might be they can just give you a very succinct answer to the question that you have. We're also looking at how we might do shared care longer term models for patients with conditions like ADHD, where we know that there's pressure on the healthcare system and these patients are finding it really difficult to get into care and then to have ongoing care. And if we can each work to the peak of our scope and keep the care in the community, but tap into the specialist if and when needed, that will allow more patients to receive the care they need. And I guess at this point, we're really keen to hear from you what else you'd like to see, where you can see this going in the future and how we can better support your needs. I'd be keen to know if anyone's used our service and has any feedback, or if there are any questions or comments from anyone who would like to come off mute or write in the chat.
Jo, I had a question, if that's okay. I was just waiting for someone else to jump in. But
thanks, Mandy.
I'm Mandy from West Vic PHN, and my role is Allied Health Engagement Lead. I'm just my job, if you like, is to kind of engage and bring in under the umbrella of PHN Allied Health Practitioners, which is just a new initiative. I'm just wondering when I Googled it, it says that Allied Health can get involved with this, with the virtual specialist. I'm just wondering if you could sort of speak to that a little bit as well in terms of where they fit in. Obviously, billing's different, so I'm wondering how that works. I know they're super keen, and I've said to them, I'll come along tonight and I'll see what's happening, but anything that you can cover off in that area would be appreciated.
I'll throw to Cassie because I've seen she's come off mute and she's in Allied Health herself. So
Thanks, Jo. And I'm just looking, there's a question in the chat as well. Do you accept referrals from nurse practitioners? We do. We actually do have allied health clinicians joining our co-consults, and same thing, they often will join with the patients. I'm thinking of a recent example where a physiotherapist joined to discuss a case with our rheumatologist and joined with their patient to look at, while the patient was on the wait list to see a rheumatologist in public health, they were looking for some strategies to help manage that in the interim while they were waiting. So yes, we are open to allied health. We also have some podiatrists in regional areas who perhaps don't have access to endocrinology or infectious diseases, and they also have utilised the service as well. And another question in the chat is, would love to see a way for regional rural allied health professionals to access this without the GP. Sometimes this is not feasible, absolutely. As I mentioned, more than welcome to join in. The idea is that their care remains with the clinician that's on the ground with the patient. So as long as the clinician feels they're able to manage that, then we definitely encourage them to dial in. If perhaps the allied health professional doesn't feel like they're equipped to be able to manage the patient alone, we just need them to be mindful that we can either loop in with their GP, but the care does remain with the primary clinician.
Yeah, and I guess just adding to that comment about we know that access to healthcare in many rural and regional areas is super tough. And we have toyed with opening it up to direct referrals, and then we close it down again, apart from certain specialties. But it's definitely on our radar and our mind that we do need a way to facilitate getting better access to specialist expertise out to those rural and regional areas. And if people have ideas about the best way we can facilitate that, we'd be really grateful to hear them. I guess we are mindful as a service that we don't become a specialist outpatient service that is going to succumb to all the same pressures and therefore not be able to offer that timely advice. So we try very hard not to hold on to patients. We have got some exciting partnerships developing. So we've partnered with the Royal Flying Doctors Service, and we will be able to, for patients who are really living rurally and remotely, we will be able to do that one-off assessment. Some of those, we know many of those patients, when we see them through the VVED pathway, we are able to get them sorted and get them back into primary care. But for those that do need ongoing specialist care, we'll be able to refer them on to Royal Flying Doctors Service who are willing to take on that ongoing specialist care of those patients. And so I think that will open up more opportunities to support those areas where healthcare access is really challenging.
Yeah, absolutely. And as Jo mentioned, that's also been a driver for one of our collaborations that has been in place for at least 6 months now with the Royal Victorian Eye and Ear Hospital. We've been working with them providing ophthalmology care for around the state. And actually a slight pivot to the model, it's for optometrists to dial in and consult with ophthalmology, and that's become quite successful, so really taken off. And also collaborating with VACHO as well to provide care on country to Victorians who are not able to travel.
Can I ask, is there anyone on the call who's used our service other than Morgan?
We have another question here. Great service, and I can see the benefits, but I do have concerns about driving care to metro doctors and reducing in-person access to regional people. How will specialists in regional areas be engaged in this initiative, given their key role in local service delivery?
I think, sorry.
No, I wasn't too sure who was going to take that one. Morgan.
My only answer to that is, I think what Jo mentioned, and just to reiterate, with the main role of this service is to provide more of a one-off advice and then refer back to the local care team, unless there's extenuating circumstances, and each case will be case by case. But for example, if you're in somewhere quite rural, but there's an endocrinologist who comes up to visit, and that's great, but they're not up for the next 6 weeks, and you need some advice now, we're happy to do a one-off, and then obviously provide notes to the GP and the care team, potentially to that endocrinologist who usually manages the care as well. It's not trying to pull away. We're very resistant to ongoing care appointments. It's more that one-off or two-off bits of advice, and then building capacity in primary care in the community rather than just being an ongoing outpatient service.
And I guess, oh, sorry, you go. I was just going to add to that and say, like, we're very much about plugging the gaps and recognising where there is a barrier or a lack of access to healthcare, and providing that missing service. So, whilst some areas might have a visiting cardiologist, they might not have a visiting geriatrician or a visiting nephrologist. So we can look to plug that gap. But as Morgan said, if there is a service that exists, our primary aim is to link them back into that service. Cassie, sorry, can I throw to you?
No, we have Catherine has her first appointment coming later this week, so very exciting. Please, there will be a survey at the end, so please take the time to complete. We value any feedback. And we also have another question. Is there anywhere a specialist can read if interested in being a provider as part of this network? I'll put our email, the best email to get a hold of Jo and I in the chat. So please feel free to reach out with any suggestions or any, if you're interested in being part of it. A wonderful wish list would be to allow allied health access if they are in a rural remote area using MMM classifications. Jo, we have we are statewide. We have tried to divide it up using the MMM classifications, and it just became a bit confusing for some people. So Allied Health are more than welcome to join the consults if they're wishing to. We actually have some Allied Health that are part of VVSC. We have dietetics, physiotherapy, and a few others joining shortly. So if people are looking to refer into Allied Health through VVSC, there is that pathway. If they are Allied Health are on the ground and looking to consult with our specialists, they're currently more than welcome to do that. What item numbers can be used for co-consults? Morgan, you've got that? Fantastic.
Yeah, any applicable item number to the usual type of consult, sort of 23 for a time-based plus or minus private fees, and we're not, you're billing Medicare at the time we're not, and so you can do it at this. Yeah, you just bill as normal. Yeah.
I just wanted to clarify on that wish list. I meant for direct referrals, not just being part of the team. Direct referrals.
Yeah, absolutely. Like Jo said, if we don't have it, we are very privileged to have quite a pool to draw from. So, and a lot of very surprisingly tech-savvy clinicians, not that Jo and I have really given you any indication of our savviness tonight, but yeah, we have a lot of engaged clinicians and, like I said, a hospital pool and community service pool to draw from. So if there's something missing that you think we need or you would like, let us know, reach out to us. I'm popping our email in the chat, and we will do our best to add it.
We do have a little video with the sound being somewhat suboptimal, but we might play that, and if there are more questions people have, feel free to type them whilst the little case plays. It's a little case that features both Cassie and Morgan in the prime of their career.
We'll see how the audio goes, but it's just an example of what a type of virtual case conference would be. Here's me mid-blink. Here's Cassie. She's the patient. And this is one of our ophthalmologists. And this is kind of mimicking a consult that we could have had around someone who needed an ophthalmology opinion.
Nick, I'm Morgan. I'm a GP. And this is Cassie, who is one of my patients who comes to our clinic. And Cassie, this is Nick, who's an ophthalmologist or one of the eye specialists at the hospital. That's helping us just sort out what's going on. I suppose I'll dive into the issue, but effectively, Nick, we're thinking about a chalazion in the right eye. Is it all right, Cassie, if I kind of give the background and then you can jump in any time?
Yeah, sure.
So yeah, she's 32. She's had chronic eyelid eczema for a long time. We've managed it, blepharitis in the past, styes in the past, but this time I'm pretty sure we have a chalazion in the right upper lid. And over the last 6 weeks, we've been trying warm compresses, massage. I thought about Clawsy, but I didn't do it because there wasn't ever any evidence of infection. The visual acuity is okay, but it's sort of, we think it's getting a little bit bigger maybe, and a bit of rubbing on the eye when she's blinking. She can still close her eye completely. I think we're maybe looking at a procedure to drain. Cassie's also not particularly keen on needles around the eye, which is very fair. So if that's the only way, we'll go down that route. But I'm just not too sure what to do now.
Yeah. I think something you can do to try to prevent having a procedure is you could try a 4-week course of doxycycline,
All right.
which has a sort of anti-inflammatory action. And I've seen people get better by just continuing to do their warm compression and massage on that medicine.
Yeah, right.
It's 100 milligrams daily.
Yep, 100 daily.
And I think if you reach the end of that course and it's been 4 to 6 weeks and it's still there, sometimes the best thing to do is just organise a referral to a local ophthalmologist, and they can do something small to make it go away.
Yeah.
But I have seen plenty resolve on that treatment regime as well.
Yeah, all right. No, I think that's good. I didn't know about the doxycycline, so that's interesting. So, Cassie, that's a type of antibiotic. It's a pretty safe one. It's we can go through it a bit, but I think it'd be worth starting that basically today, and after we have finished.
I think just to make sure we have time for questions, I'll leave it there. But in essence, what it does is it provides the opportunity to that kind of advice of, do I need to send this patient in for an operation? And the interesting thing is, I actually didn't know legitimately as a GP about that doxycycline, so I learned something during that video that we filmed. And so we could bypass a long wait time and a potential unnecessary operation by having the early case consult. The end of that is also the patient, Cassie, is very uncomfortable about having needles going near the eye. And so we were all able to explain together why we want to avoid that, but then why it may end up at that, and how we could all support her with that experience. So just a bit of an idea of one way it could be used, and you could maybe get in to see Nick, the ophthalmologist, within a week or two.
I'll just take this opportunity to thank all our speakers for such a great presentation, very informative, and we're lucky that you were able to deliver that for us. So thank you so much. And don't forget to get into contact with the team there. They've got their email address and stuff in the chat for you. We've got our evaluation survey if you'd like to fill that in. Any last words from our presenters?
No, thank you for the opportunity to share our service. We'd be very keen to hear any suggestions, and look forward to hearing some feedback when you do try us later in the week. I think it was, who's using us? Catherine. Let us know how you go. Thank you very much for your time this evening.
Thank you.
Yeah, the only other thing I'll say briefly is excellent opportunity for teaching if you've got registrars as well, especially because they can have that slightly longer consult and really take their time to tease out how to manage a condition in depth. So yeah, hopefully it's helpful.
Thanks, everyone. We'll finish the webinar now and see you all again at the next one. Thank you.